Bueno, buenas tardes a todos. Muchas gracias por sumarse a este webinar que organizamos junto con la doctora Diana Morales Castro, que también está logueada aquí. Voy a hacer las introducciones primero en español y luego en inglés. Mi nombre es Federico Carini, soy médico intensivista de Argentina, del Hospital Italiano de Buenos Aires, y es un honor para nosotros, junto con Diana, presentar y tener aquí con nosotros a Lisa Higgins, que es la head del Health Economics Program en la zona de Australia y Nueva Zelanda, y que nos va a presentar el trabajo sobre la costo-efectividad de la movilización precoz en terapia intensiva, un subanálisis del Team Trial, que como todos ustedes saben ha sido un hito en la investigación en esta área. So welcome everyone to this webinar. For everyone to know, this is going to be done both in English and in Spanish. This is going to be presented in English, and you have the option to change the language. If you click on the world logo, you can change to Spanish. So, Lisa, welcome. Thank you for joining us. It's a pleasure for us as a group to have you here in this webinar to speak about this very critical topic of early mobilization in the ICU. Lisa, as you know, is the lead of the Health Economics Program in the Australian and New Zealand Intensive Care Research Center at the Monash University. So, Lisa, the floor is yours. Thank you for joining us.
Thank you so much, Federico. And please, if I do need to slow down with my speaking for the translator during the presentation, please just, Federico or Diana, please unmute and let me know. So today I'll be presenting the economic evaluation of the team trial. So just to begin with, these are my disclosures. So the team trial was a trial that was completed in 2022 and published in the New England Journal of Medicine. And it was a randomized controlled trial looking at the effects of early active mobilization in patients who are mechanically ventilated in ICU. So in the team trial, we had 49 sites across 6 countries, Australia, New Zealand, the UK, Ireland, Germany, and Brazil. So it was a big international trial. The primary outcome of the team trial was days alive and out of hospital to day 180. And we found no difference in the days alive and out of hospital. You can see there 143 days in the early mobilization group and 145 days in the usual care group. But what we did find was an increase in adverse events. So there were more adverse events in patients in the early mobilization group. And so what we pre-planned an economic evaluation because we wanted to see the impact of early mobilization. What is the impact of these adverse events? While there's no difference in days alive and out of hospital, there might be what we call downstream effects. So it might be that they needed less organ support, which then reduces the amount of staffing required, and that might be something that saves some costs. But obviously, performing early mobilization, particularly in ventilated patients, requires additional staffing. So after the team trial, this meta-analysis was published in NEJM Evidence, and this trial did show, this meta-analysis did show that there was potentially some improvements in physical function and things, but it included 15 trials. And so of those 15 randomized controlled trials, none looked at cost or cost effectiveness. They did find that there was a favorable reduction in days alive improvement in days alive and out of hospital, although it wasn't significant. But when this happens, when it looks like there might be benefit, it's really important to look at cost effectiveness. And none of the 15 trials up until this point had ever looked at costs or cost effectiveness. So why do we need health economics? So I have 3 children. My 3 children like to think that money grows on trees. Very sadly, money does not grow on trees, and we really have limited resources. And we all make decisions every day about how to spend our money. So I've got Australian Airlines here. So Jetstar is our low cost, cheapest airline. We have Qantas. Most people have probably heard of Qantas. It's our flagship Australian airline, better quality, but more expensive than Jetstar. And then obviously you could fly private jet. Now, when I go to conferences, I have to make a decision. I have a limited budget. Do I fly the cheapest airline? Do I fly Jetstar and not have food and not be able to go to the lounge and a less comfortable seat? Do I fly Qantas so that I have good food, lounge access, nicer seat, more comfortable? Do I fly a private jet and have everything I want? Obviously, I am trading off benefits, my comfort, the food, and costs because every time I step up, it costs me more. That's what we have to do in our healthcare system. So we all have unlimited wants. If we had everything, we would want everything, but we have limited resources. And resources isn't just money. It's ICU beds, it's ICU nurses, it's theatre time and space. So every time a decision is made, for example, to give a patient an ICU bed, that bed isn't available for someone else. And that's why we do health economics. We're trading off the benefits and the costs. So this is particularly important in healthcare because, as I'm sure many people have seen, the percentage of healthcare costs that governments are spending, as a percentage of GDP, it just keeps rising and it's just not sustainable. We have limited resources and there's always in what we call in health economics opportunity cost. So there's other things we could do with resources. When we give a patient an ICU bed, that bed is not available for someone else. When we buy a new piece of equipment, that money is not available to do something else with. So that's why we talk about opportunity cost. And what we're looking at doing in health economics is maximizing the benefits that we can get given our available resources. So given there is a 10-bed intensive care unit, which patients should go in so overall we get the best outcomes? Or if we have $1 million to spend, how can we best spend that money so that we get the best outcomes? This is particularly important in intensive care because intensive care is very expensive compared to most other parts of the healthcare system. And so we use a large amount of the healthcare budget on a very small number of patients. And we have to be able to justify that because it means that the very large group of patients not in intensive care aren't able to access the resources. We're using a lot of money in intensive care that now isn't being used in other parts of the hospital or the healthcare system. And so the key thing is we just can't keep spending more money on marginally effective treatments. That money could be used elsewhere in the healthcare system to get better outcomes, to have more health gains. So in terms of economic evaluations, there are different types of economic evaluations we do. And so you'll see words like cost effectiveness, cost utility, cost minimization, cost benefit. But they all involve measuring costs for two or more interventions. They all involve measuring the benefits associated with those interventions. And then you combine the costs and the benefits. So what additional benefit do I get for what additional cost? Most commonly in intensive care, you'll see cost effectiveness and cost utility evaluations. A cost utility evaluation is basically a type of cost effectiveness evaluation where we use what we call QALYs, which are quality adjusted life years, which is just a combination of quality of life and survival. So it's not just about whether someone survives, it's about what's the quality of that survival. So regularly in intensive care, we present what's called the cost effectiveness plane. And you'll see this graph. And when you see it later on, when I present it, there are lots of dots on it. But the key thing here is the y-axis is the difference in costs, and the x-axis is the difference in effects. So in the top right quadrant, you pay more money, but you get better outcomes. In the top left quadrant, you pay more money, but you get worse outcomes. So clearly you don't want anything in that top left quadrant because you're paying more money and getting worse outcomes. In the bottom left quadrant, that's where it costs less, but also the outcomes are poorer. That's a really hard quadrant to be in because you have money to spend elsewhere, but the patients are not as good, have worse outcomes. And then you have the bottom right quadrant. This is where you want to be. You're saving money and patients are getting better outcomes. That's very rare, but when you do an analysis and something is in the bottom right quadrant where it's saving money and getting better outcomes, that's fantastic. So we now at the Intensive Care Research Centre, we do economic evaluations alongside all of our trials because we think it's really important. We use a large number of resources in intensive care for a small number of patients. And so we need to ensure that anything we're recommending is providing value for money. And if I give an example, if you had a treatment that cost $1 billion but saved someone's life, we probably wouldn't do it in the healthcare system because we don't have $1 billion to spend on every patient. Now, obviously that's an extreme example, but we might do a trial and say, yes, this treatment saves lives. If that costs $1 billion to save a life, it's not something we would do, even though we know it saves a life. And what we're doing in economic evaluations is saying, well, how much are we having to spend? And then it's up to the healthcare system and governments and policymakers to decide, are we willing to spend that much money to get that outcome? So in the team trial, our aim was to assess the costs, quality of life and cost effectiveness of early activity and mobilisation compared to usual care in mechanically ventilated ICU patients in the team trial. Now, the team trial collected data to 6 months, and so our economic evaluation is looking at the costs and the outcomes up to 6 months. So the team trial had a statistical analysis plan, and just important to recognise that we pre-specified this cost effectiveness analysis. So our plan and everything we were doing was all pre-specified before the trial results were known. You can read, there's a lot of words here, you don't need to worry about it. It's more just to say this was pre-specified. So as I said, it was planned a priori. So we did this in collaboration with the health economics group at Monash University. So it's a within trial cost effectiveness analysis. So what that means is we used trial data. We didn't use additional data from other evidence that people may have. Our time horizon was 6 months, meaning we only looked at the outcomes and the cost up till 6 months. We used a healthcare payer's perspective. So what that means is we looked at the costs to the healthcare system, not the costs to the patients. So in the majority, actually, I think in all of our countries that were participating, in the sites that were participating, they were government-funded hospitals. So the patients weren't paying out of pocket. But we didn't include things like when patients had to drive back to hospital for appointments, if patients had to take time off work for appointments or time off work when they were ill. We didn't include that because we just did a healthcare payer's perspective. So what it costs the government to provide the healthcare. And then because it was an international study, we did some subgroup analyses. So we looked at Australia and New Zealand, which had the majority of patients. We looked at a European group, so Germany, Ireland, and the United Kingdom. And then we effectively did a non-Australia New Zealand group. So it was Europe and Brazil together. So as I said, economic evaluations involve measuring costs and outcomes. So in terms of what we included for costs, so we measured the resources used during hospital admission. So we measured to provide the early mobilisation and also to provide whatever usual care was at the site. We measured what staff delivered the intervention, how long it took them, all of those things, how long it took to set up if they were using equipment like a tilt table, if they were getting the patient out of bed, how many staff and how long, so that we could cost all of that staff time. We looked at organ support days. So there's great research in the UK that shows that every ICU, and everyone knows, every ICU patient is not the same. A patient needing ECMO and dialysis and ventilation requires more staffing time than a patient who's in ICU just receiving vasopressors, for example. And so we applied a cost per day of ICU, which depended on how many organ supports you had on that day. So if you were on ECMO and vasopressors and ventilated and on dialysis, you were much more expensive than someone who was just ventilated and not on those other organ supports. We then looked at how long they were in ICU. So we had that cost every day, and that cost changed each day depending on how many organ supports you had. And then after they were discharged from ICU, we applied a cost to their ward stay, and that was just a fixed cost for each ward day. Then after they were discharged from hospital, we measured any inpatient rehabilitation they had. So we had a cost for each day of inpatient rehabilitation. If they were readmitted back to the hospital, we had a cost when they were readmitted back for each day they were back in the hospital. Then we had high-level care days. I'm not sure what you call that in Latin America. That's nursing home, where someone lives somewhere where there are nursing staff and requires full-time care. And then we had low-level care days and transitional living days. So these, particularly in Australia, are centres where people are living in supported accommodation. There are nurses, but they can usually shower themselves. They don't need as much support. So we collected costs. So for each of those resources, so like what does an ICU day cost? What does a rehab day cost? We collected the information from each country because obviously the costs of things differ greatly between the different countries. So we then took the resources. So for example, we took the ICU days and we times it by the cost to get a total ICU cost. We did that for each country. So if it was a patient in Australia, we applied Australian costs. If it was a patient in the UK, we applied UK costs. If it was a patient in Brazil, we applied Brazilian costs. We then converted all the costs to a common year, and then we converted all of the costs to United States dollars, because obviously all the countries have differing currencies and we need them all in the one currency. And the way we do that is we use what we call purchasing power parity. So we don't use exchange rates. And the reason for that is if I have $5, it's called the Big Mac Index. If I have $5 here to buy a Big Mac, if I convert that into US dollars and I go to America, it might actually not be enough money to buy a Big Mac. And so what purchasing power parity does is it says you have this much money in Australia. How much do you need in America to get the same product? So if an ICU bed day costs $6,000 in Australia, purchasing power parity converts it to US dollars, saying how much would it cost me to get an ICU day in the United States. It's not a great example because healthcare is obviously different, but this is like across everything, food, transport, what would it cost to get the same product? In terms of outcomes, so we measured quality of life by phone. So the sites called the patients at 6 months and did the EQ5D 5L over the phone with the patient. It was missing for 10% of patients. It's sometimes hard to get in touch with patients 6 months after they've been in ICU. And so we used multiple imputation methods to account for that missing data. With the EQ5D, you can take the results of that questionnaire and convert them into what we call a utility score. And we take that utility score to work out the quality adjusted life years. So we used the UK time trade-off tariff. So there's different ways you can convert to utility scores. When you do an international study, we typically use the UK time trade-off tariffs because that's what's recommended for international studies. We assumed a utility of 0 at baseline. So one of the challenges in ICU health economics is we don't normally know the quality of life of patients at baseline because most people don't know they're coming into intensive care. So when you're doing a trial, you can't have met these patients before they're in ICU. It's common in economic evaluations in ICU to assume a utility of 0 at baseline. So utility scores are anchored at 0 is the equivalent of dead, 1 is perfect health, and you can actually have negative scores. So you can actually get a negative utility score, which is considered being worse than dead, because there are some situations where people are so poorly that they would actually prefer death to how poorly their state is. We assume a utility of 0 at the time of randomization because these patients are in ICU, they're sedated, and it's reasonable to assume that your quality of life at that point is the equivalent of death until you recover. We then collect the quality of life at 6 months, and we effectively assume that it increases from 0 up to that time at 6 months linearly. We then calculate quality adjusted life years. So we take the utility score and we times it by survival. So if you die, you get 0 utility, you get 0 quality adjusted life years because you've died. And for everyone else, we calculate the utility score, which is generally between 0 and 1, and then we times it by that 6-month period if you survived to 6 months. And the reason we do this is qualities are very common in economic evaluations because they're like a universal outcome. It means you can compare ICU to orthopedics or to neurology or to dermatology when you're trying to work out where to allocate resources in the healthcare system. It gives everything the same measure. So you can go, what does it cost to get 1 quality in ICU? What does it cost to get 1 quality in dermatology? You know, which one is providing the better outcomes for the same money? So as I've said, we did a within trial analysis. Of the randomized patients, we excluded 8 of them because either they were lost to follow-up and we can't, with economics, you need to know all of their dates that they were in rehab, ICU to be able to allocate costs, or if patients withdrew consent. We have a thing called discounting in health economics, which is where if I could give you $100 now, or I could give you $100 in 10 years, people want the $100 now. Money now is worth more than money in waiting 10 years for it. So we don't have to do that though because our analysis was only looking at a 6-month period. So we look at the costs and outcomes for the 2 different groups. So for the early mobilization group and the usual care group, both overall and then according to geographical location. And then obviously statistically, so we had mixed effects generalized linear models, which accounts for variation across sites. And then we do a bootstrapping procedure, which looks at the uncertainty around the costs and effectiveness. And you'll see that when I present the results. So this was published just a couple of months ago in Critical Care Medicine, and you'll be able to get a lot more detail than you can get in my talk today. So I would encourage you to read it if you're interested. And obviously there's a lot more detail in the supplement for this as well. So if we look here at the costs, so you can see in 70,000 on average, the people in the early mobilization group cost $70,000 US to 6 months, and the usual care group costs $68,000. So meaning slightly more expensive, but what you can see there is a really wide confidence interval. So they could be cheaper, they could be more expensive. And this is one of the challenges we have in health economics, because when we do randomized controlled trials, we power the study for whatever our primary clinical outcome is. And because costs are so much more varied, typically health economic evaluations are quite underpowered to be able to detect differences in costs. And what you can see here is for all of the 95% confidence intervals on the far right, they all cross zero. So it means there wasn't a significant difference in costs for any of the groups. So even though, for example, Europe is $10,000 cheaper, you can see that confidence interval goes from $28,000 cheaper to $23,000 more expensive. So we can basically say there wasn't a difference in costs. In terms of outcomes, so what we're presenting here is this is the quality, so the quality adjusted life years. Now, the most you could have in 6 months is 0.25 because we start at 0, we could go up to 1, and that creates a triangle that's half a year. So the most it could be is 0.25. So you can see these patients got around sort of half. Now, some of that is because of death, and obviously some of it is because of poorer quality of life for patients after they've been in intensive care. So you can see if we look at the right-hand side, the difference in the quality adjusted life years. So in all of them, the quality adjusted life years are lower in the early mobilization group, but there are no significant differences. All of those confidence intervals cross zero. So there are no significant differences in quality adjusted life years, even though all of the point estimates favor usual care. So if we look at cost effectiveness, so that's where we take the costs and combine them with the outcomes to look at whether something is providing value for money. So what we have there is we have the costs in both groups, which I've already shown you. Then the incremental cost is what's the difference in costs. Then we have the quality adjusted life years in both groups. And then we have the incremental effect. And so what we do in a cost effectiveness analysis is we take the difference in cost and we divide it by the difference in the effect. Now, because the mean cost difference is that it costs more, and because the mean effect difference is that it has worse outcomes, lower qualities, the incremental cost effectiveness ratio is what we call dominated because it's in that quadrant I was showing you before where something costs more and gives poorer outcomes, which obviously isn't a good thing. But remembering that there is a lot of uncertainty around this, which I'll show you. So we work out a thing called the incremental net monetary benefit, which is looking at if I was willing to pay $50,000 for a quality adjusted life year. Now that's a typically accepted threshold. In general, governments say if something costs $50,000 or less to get a quality adjusted life year, governments generally say that's value for money and we will pay for that. So what we do is we take the costs and effects and we say, if we were willing to pay $50,000 per quality, what incremental net monetary benefit would we get? Negative means we wouldn't want to pay for it. It's costing more than $50,000 per quality. And you can see here it's negative, but again, the confidence interval is very wide. So there's a lot of uncertainty. The confidence interval goes up to $10,000, which would be providing definite value for money. So this is the cost effectiveness plane, and you may remember I showed it to you earlier with the 4 quadrants. And where we didn't want to be was that top left quadrant. What you can see here is that there is spread around all of the quadrants. So in that bottom right quadrant, which was the quadrant we really like, where it costs less and gets better outcomes, there are still dots falling there. So this is where we've taken 10,000 bootstrapped replications. So we've replicated the data 10,000 times and worked out the combination of costs and qualities each time. And so what we can basically show is there's a lot of uncertainty around the results because there is data in all 4 quadrants, which makes it quite challenging. 54% of this data is in the top left, so it costs more and has worse outcomes. So that's obviously not a good thing. And I told you just before that $50,000 per quality is generally the accepted amount that governments are willing to pay. So the probability that early active mobilization was cost effective if you're willing to pay $50,000 per QALY, is only 34.8%. So it's quite a low probability of being cost effective. Now, we did this across the different countries, and what you can see is generally there's no difference between the different regions. They all have very spread data. Occasionally, we see that one country, an intervention might be particularly good in one country simply because of how costs are distributed. We haven't seen that here. Generally, the results are consistent across all the different regions. So this was the first study which looked at cost effectiveness of early mobilisation. There had been lots and lots of randomised controlled trials beforehand, but no one had ever looked at the costs and cost effectiveness. As I said, one of the key things is that when we design randomised controlled trials, we power them for the clinical endpoint. It generally means it's really hard to do an economic evaluation because there is a lot more variability in costs, and so economic evaluations tend to be underpowered. Obviously, there are some limitations to this. The team study was an unblinded study. One of the key things is that the usual care group in the team study had a lot of mobilisation. So the team study wasn't comparing early active mobilisation to no mobilisation. The usual care group got a lot of mobilisation. So all we're saying is that giving more mobilisation and earlier mobilisation compared to what the usual care group got isn't value for money. It doesn't say anything about whether mobilisation compared to no mobilisation is value for money. We didn't do a trial comparing mobilisation to no mobilisation. And what we do know is that the majority of patients in the team trial were randomised in Australia and New Zealand, and we were already doing quite a lot of mobilisation in Australia and New Zealand. So our usual care group looks like a mobilised group. They had a lot of mobilisation. And so all we're saying is that doing more mobilisation above what we normally do in Australia doesn't provide value for money. So in summary, early active mobilisation didn't affect the number of days alive and out of hospital compared to usual mobilisation. It was associated with increased adverse events. We didn't find evidence to suggest that it improves quality of life or reduces costs compared to usual care. And so we found no evidence that it's a cost-effective intervention, remembering that it's early active mobilisation compared to usual care mobilisation, where there was quite a lot of mobilisation in the usual care group. So I would just like to thank everyone involved in the team study. We had a fabulous management committee, our funders. In particular, I'd like to thank Yongyi Lee at Monash University, who led the majority of this analysis. And as always, we always like to thank our participating sites. We had wonderful sites across 6 countries, and without the amazing sites, we can obviously never do our trials. But I've hopefully left a lot of time for questions because I'd be very happy to answer any questions people have.
Thank you, Lisa, for that presentation. I think it's been very enlightening, and I'm sure there will be a lot of questions. While we wait for people to give us their questions, I wanted to start by asking you, Lisa, what is a typical day in an ICU for a patient who is admitted there in Australia? We read with a lot of interest the team trial published originally in 2022 by your team. And to be honest, and I'm sure you're all aware of this, it was quite shocking to see there was no difference in the 2 groups. And this was assumed by some people to mean that early mobilization had no use, and in fact, it could be harmful for patients. So it was very important for you that you mentioned that you already are doing a lot of mobilizations, and you've been doing that with Carol Cox and teams for quite a long time. But it would be nice to hear you walk us through a regular ICU day for a patient there in Australia.
Yeah, so in all ICUs in Australia all have physios, dedicated physios in ICU. And so in Australia, a typical day, a patient will always be assessed by a physio. And if a patient is capable of being mobilised, they will be mobilized. And so that's very different to a lot of other places in the world where, so our usual care involves a physio seeing the patient every day. What we were doing in team is saying, let's try and get them up and out of bed earlier. So whereas normally a physio might go and start with some active exercises in bed, in the team trial, we were saying, no, if we think they're capable, let's stand them up. Let's not do active exercises in bed. So we were trying to do higher mobilization earlier. But a typical day, a patient will always be seen by a physio, and if they're capable, they will be exercised. So that's what usual care is. And so all we're saying is doing the additional, trying to get them out of bed rather than doing in-bed exercises first, that type of thing. Normally, we'd start with in-bed exercises and then maybe the next day sit them over the edge of the bed, maybe the next day stand them up. That's usual care. In team, we said no, if they're strong enough, stand them up straight away. And so we still have a lot of mobilization in our usual care. And so all we're saying in the team trial and the cost effectiveness analysis is that doing things like standing them up earlier before you do the in-bed exercises and doing more, spending longer with the patient isn't value for money and doesn't provide a beneficial effect.
I just have,
I'm very, oh,
sorry, Diana,
sorry.
I just wanted to do one follow-up to that question. Um, I understand that cost effectiveness analysis, of course, is relative only to the team trial. But in your opinion, if we were to compare usual non-Australian care in terms of mobilization, which usually is much less than that, to what you're doing in your usual care, do you think that that would be cost effective?
Look, no one's assessed it, so it's hard to know. But the meta-analysis data shows that when you look at the studies that look at mobilization compared to no mobilization, there is benefit. So it's probably cost effective, but it just depends on how much it costs to live. We know that that's the limited data we have tells us that is effective. It is better for patients to have mobilization compared to no mobilization. No one's looked at whether it's cost effective, but yeah, when you look at the meta-analysis, when it takes the subgroup of mobilization compared to no mobilization, there are definite patient benefits.
Thank you.
Yeah.
Yes, Diana, please.
Yeah, I think you need to run this study in Latin America. I'm gonna say at least so, I see here in Toronto, like patients doing exercise on ECMO, walking with their ventilators, or even like passive movements in the bed every day, a whole team of people dedicated to this. Even the nurses are very well versed and stuff. And then I go and practice in Costa Rica, and we have no dedicated physiotherapist. It's the same physiotherapist that is rounded for like the rest of the hospital that comes here and see whose patients or which ones do they think they can do something for, and those are the ones they focus once a day for a little bit and then they leave. And the reality is a lot of other ICUs don't even have that, like, because we're like in one of the biggest centers. So I would be very interested in like how will those results be in a place where we are really not doing anything for our patients or not enough for our patients.
Yeah, and it's a real challenge of the team trial because we've really tried to be very clear that it's not showing early mobilization isn't effective or cost effective. It's showing that additional and earlier mobilization isn't beneficial compared to what we already do in Australia. We obviously can't do a study in Australia comparing usual care to nothing because it wouldn't be ethical. So the only place that can, that randomized control trial can only be done in countries and settings where usual care mobilization isn't a common occurrence. So places that don't have dedicated physios. In Australia, every ICU has physio, and so patients are always being mobilized. So it's a really important point that this doesn't show that early mobilization isn't effective or cost effective. It shows that earlier and higher level mobilization isn't effective and cost effective compared to what we usually do in these countries, which is primarily Australia and New Zealand.
Yes, we have a question in the chat from one of our colleagues from Mendoza in Argentina. And he asked, bearing in mind the limitations from a hospital in Latin America, from the public system with the limitation in terms of funding, which do you think would be the main outcomes we should have take into account when we try to prioritize this budget? Do you think there is any kind of platform, either online, that could be useful to organize that data?
Well, it's really tricky because obviously you want some type of patient outcome. You want the patients to be better, but that means you have to be able to measure a patient outcome. That being said, you can, for example, have someone measure patient function at hospital discharge. Now, that could be you could measure their muscle strength, or you could measure their activities of daily living. You know, what are they able to do? You know, we did we've recently finished Carol and I have recently finished a study of mobilization in ECMO patients, which we're actually presenting on Wednesday Australia time at CCR Down Under. So if anyone's around, it's freely streamed online. You can stream it. Although I have no idea what time it will be. It might be the middle of the night in Latin America. But in our pilot study for that, we did show improved activities of daily living at hospital discharge. So there are simple things. It's much harder and requires a lot of resources to follow patients up after they've left hospital, which is why we usually only do it in trials that have funding to do that. But there are things you can measure in the hospital, like strength or activities of daily living. And if you can do that, then you can look at, okay, well, what resources did we need to mobilize the patient, and what outcomes do we have? And the data that you need for costs is pretty easy because your hospital already has the data on how long they were in ICU, how long they were in the ward. All of that is available, and you just apply costs to that data. So there are certainly things you could do. You could measure when patients are mobilized. It's hard outside of a randomized controlled trial because obviously the people that get mobilized are different to the people who don't get mobilized. You know, you mobilize the people who are not sedated and awake enough to participate and not delirious. So it's tricky to do and get accurate results without a randomized controlled trial. But I think the data is really helpful to be able to just understand how are these patients functioning when they leave hospital.
Okay, Lisa, after you publish this cost effectiveness analysis and with the result of the team trial, have you seen any change in your way of practice there in Australia with the information you gather and what you learned in this trial and with the evidence you produced?
People in Australia are still doing usual care mobilisation. We did a lot of work, and there's a publication led by one of Carol and my PhD students, Tessa Broadley, looking in detail at the adverse events that occurred in the team trial. And what that basically showed is the adverse events were only occurring when we got patients out of bed. And we were doing that earlier than we would usually do. So you may remember I said one of the things, the intervention in the team trial was if they were strong enough to stand up, you should stand them up. And so we were potentially doing that on day one in some patients. We still very much do usual care mobilisation because we've been able to look at that increase in adverse events and go, okay, well, that's occurred because we were doing more and earlier. It wasn't happening with usual care mobilisation. So people are still doing the usual care mobilisation. And the thing I think that's important here is, when we do, if we had, for example, found a benefit, we wouldn't have even been able to implement it straight away because you would need to get approval for funding for extra physios. The team trial, we paid the sites so they could have more staff to do the intervention. But it's not a trial where if we found benefit, you could have just done it. You need more staff. So in the team trial, things are just happening as they were before the team trial. Patients are still being mobilised. They're still being gotten up and out of bed, but just not at that really, really early stage.
Thank you, Lisa. Diana?
Yes. So, and this may be a question that you probably may or may not have the answer, but I'm very curious. We started doing all these like economic evaluations very recently for critical care, and I wonder if you've studied overall how well are we doing with our critical care services? Like, are we too much beyond what like governments define as like something that is affordable for a quality? Or are we still safe?
So it's really challenging actually because we actually don't have trials that compare putting some or very few trials that compare ICU to someone not going to ICU. So nearly all of the economic evaluations that are done in ICU are comparing different interventions in ICU. So like team, early active mobilization compared to usual care mobilization. But that doesn't tell us anything about ICU compared to not ICU. There have been a couple of trials. They're very, very old and probably not relevant to now. They did show, the economics of those did show benefit. So they show it is cost effective. But, I look at, for example, Australia and I compare it to the UK where I have a lot of knowledge of their system. And, we put much less sick patients in ICU in Australia, for example, than they do in the United Kingdom. And it is very specific to the location and to the setting because it depends on how many ICU beds you have and how sick the patients you are putting in are. So I was recently in Africa and I can't remember which country. We had a critical care meeting there and I can't remember which country it was, but the country has 10 ICU beds, and I think, Victoria, the small state where I live, which has the same number of the population as the country, has 700, and so it's very dependent on the setting. It's not like we can say ICU compared to not ICU because 100% ICU in a lot of situations is definitely cost effective because the alternative is death. But it's very setting dependent. In a well-resourced country like Australia, where I am, patients get put in ICU who in a lot of countries would never be eligible for ICU because they simply don't have the resources to put those patients in ICU. And we actually don't know the answer to that. And it's a really challenging one because we do spend a lot of money on intensive care as a proportion of the hospital budget.
Yeah, it's very interesting because, so I did all my medical training and anesthesia first in Costa Rica, and I'll have patients vented on the floors or on pressors because they're not on too much pressors or they're already too elderly, too comorbid. Like, no one is going to give me an ICU bed for that. And then, here it's like the complete opposite. It's like a
Yeah.
DKA will get an ICU bed because we have the resources. So, but it's very interesting. I
And
really want to
we
say
talk.
thank you.
Oh, it's absolutely my pleasure. Absolutely my pleasure. And hopefully, some people can come, although it'll be available after our ECMO rehab results presentation on Wednesday, which is mobilization for patients on ECMO. We can have a whole discussion about the economics of ECMO. There will be an economic evaluation alongside that trial too.
Amazing.
ECMO is particularly expensive, so
I can't wait to see that seminar. It's going to be amazing.
thank you all. And people are welcome to email me if they have other questions. Always willing to chat to people.
Thanks a lot for sharing
Um,
your knowledge and your time with us. We really appreciate it, and it's amazing that you dedicate some time for us in this region of the world.
My absolute pleasure.
Thank you, Lisa. Y gracias a todos por conectarse. Thank you everyone for connecting. We'll see you next webinar. Thank you, Lisa, again for your time and your hard work. Thank you.